Okay, so this is the last part of chapter 12. And I know I've started here a little bit before we left off, but I just kind of want to make sure we're all on the same page. So just remember when we're talking about the causes of schizophrenia that there are some type of diatheses, like a biological predisposition, that it's only in the presence of a stressor, some type of event or some type of other psychological stressor that diathesis will actually manifest and schizophrenia will develop. So diatheses plus a stressor is what are needed in order for schizophrenia to manifest. And again, this is consistent with the diathesis stress model. So in lecture, we talked about genetics and how there are many different types of studies that have shown a strong genetic component or a strong biological component to schizophrenia. We looked at family pedigree studies, so I went over this in class, so I'm not going to spend too much time here, but looking at how relatedness to an individual with schizophrenia increases a risk for schizophrenia. And then a little bit more specifically, studies from genetic linkage studies and molecular biology have specified different genes and the potential deficits on those chromosomes that can lead to schizophrenia. So in this sense, schizophrenia, it's not just one gene that causes schizophrenia, but multiple genes. Schizophrenia is a polygenetic disorder in this sense, that multiple genetic defects are what predispose someone to schizophrenia. And then we also talked about the dopamine hypothesis. So this is something that we went over in class and encourage you guys to definitely understand this, read about it in your textbook so that you really do understand what's happening with respect to this biochemical abnormality. And then we also highlighted how different brain structures are maybe abnormal, or there's some type of structural deficit that can predispose one to schizophrenia. And then last but not least, looked at how not just genetics, but also viral infections that a pregnant mother is exposed to and experiences rather can disrupt normal brain development in that developing fetus, thus predisposing that fetus to schizophrenia. So that's where we pretty much left off. But what's important to understand is that biology just really sets the stage for schizophrenia, and that there are other types of stressors that are necessary in order for schizophrenia to manifest. So let's take a look at these social cultural influences. Social cultural theorists believe that there's really three main social forces that can contribute to schizophrenia. And one of these social forces involves multicultural factors. So research shows pretty consistently that the rates of schizophrenia are higher in African Americans, than Caucasians. So rates of schizophrenia are higher in this ethnic group compared to Caucasians, and experts question why. Why is this? It could be, one potential explanation is that African Americans may just be more prone to schizophrenia. It may be something about their biology or the way they are wired that leaves them especially sensitive to developing schizophrenia. Another possibility is that clinicians from majority groups, so for example, clinicians who are Caucasian, may unintentionally, or sometimes as history has shown, may intentionally misread cultural differences as symptoms of schizophrenia. So again, it's possible that clinicians misread cultural differences as symptoms of schizophrenia. This image you see here on the right of the slide is an actual ad that was advertised or that was shown or distributed. I think it was the 1960s, 1970s, but this ad, it's a two-part ad for Haldol, okay, which is a antipsychotic medication used to treat schizophrenia. And look at the headline here. Remember the time, I talked about 1960s, 1970s, this idea that if a person is assaultive and belligerent, right? If they're against society's norms, if they're not compliant, if they're not being cooperative, then perhaps they need an antipsychotic, which is known as a treatment for schizophrenia. So, if you consider the era, 1960s, 1970s, when civil rights was, especially for African Americans, was at its peak, a lot of movement during that time, we have these advertisements about, hey, let's get these guys in line. Let's make them more cooperative, less unruly by giving them an antipsychotic, right? Implying the diagnosis of schizophrenia. So yes, there was a period in history when schizophrenia or a psychotic disorder might have been diagnosed because of that just the differences, the cultural differences, like the slide said, is misread as a symptom of schizophrenia. But it's also possible that because of cultural differences that individuals from the majority unintentionally, because they're unfamiliar with behaviors and common values and common ideologies and common behaviors in people from other groups, that they label those behaviors and ideologies and values as abnormal and potentially like schizophrenia. Another theory for why rates of schizophrenia are highest in African Americans, and my little circles stayed on the slide, that's awesome. But another reason why the rates of the rates of schizophrenia in African Americans might be higher than those other ethnic groups has to do with economics. Right? So African Americans and Hispanic Americans as well are more likely to be in lower SES groups. So like we talked about earlier in lecture, how that downward drift theory, right, where individuals who have schizophrenia are more likely to be in the lower SES groups, and at the same time, those with schizophrenia are more likely to be in the lower SES groups. Those of lower SES economic status or SES status are also more likely to have schizophrenia. And race is definitely a confound in that correlation between schizophrenia and SES. So what this implies is that there are many, as the slide states, there are many social cultural influences that may help explain why schizophrenia is more likely in minority populations like African Americans and Hispanics. A second social force concerns social labeling, and this, in the beginning, it's going to sound like the slide we just talked about, or I just talked about, right? So social labeling, the idea here is that many social cultural theorists believe that society actually labels people who do not conform. Right? Again, very similar to the slide we just talked about, or again, I just reviewed. But this social labeling force, right, the second of the third forces, this social labeling force adds that once a label is assigned, it becomes a self-fulfilling prophecy, right? So once a person is labeled as schizophrenic, then essentially that label promotes the development of other schizophrenic symptoms. Right, that's the notion of the self-fulfilling prophecy, that when a person is labeled as something like a schizophrenic, then they start to take on those behaviors and those odd thoughts and those social impairments. Right, they start to take it on and adopt the part, kind of act the part, not necessarily excusing existing behaviors, but when you believe, even if it's false, when you believe that you are something, it's very likely that the anxiety about behaving in that way actually affects your behavior. So that's the self-fulfilling prophecy. When our anxiety about behaving in a way that supports a stereotype, actually influences our behavior. Another example, right? Females are stereotypically bad at math. So if I go in and I have a math test, if I believe that I'm supposed to be bad in math, then my anxiety about being bad in math is actually going to cause me to be bad at math, right? That's the self-fulfilling prophecy. And that's what the second social force is arguing. It's that when a person is labeled with a mental illness like schizophrenia, it promotes the development. The individual essentially acts in such a way to support the development or to support that disorder. And there's actually a national group that's looking into, it's called the Inquiry into the Schizophrenia label, and is very involved in trying to combat the stereotype of how non-compliance and how aggressiveness and other features associated with minority groups, how those characteristics are essentially associated with schizophrenia. Right. So then the third social force is family dysfunction. Many studies show that schizophrenia is linked to family dysfunction. So, for example, what research shows is that parents of those with schizophrenia, so if you have someone who's schizophrenic, their parents, right, their parents tend to display more conflict. So that can be conflict between them, conflict with the child, just an overall sense of conflict within the family unit. The parents also tend to display difficulty with communication. So communication patterns are unhealthy. There's a lack of communication, or there's oftentimes implied communication where people, family members start to make assumptions about what other people are trying to say and then act as if, okay? And that has a lot to do with this third element of family dysfunction, is that individuals who are schizophrenic, their parents tend to be more critical and over-involved in the individual's life, in the individual with schizophrenia's life. So it's not about neglect here. We're talking about parents who are actually over-involved. It's very similar to what we talked about with eating disorders and how some families are enmeshed. And in this sense, this over-involvement really includes parents who have very poor boundaries, in the sense that they allow their kiddo very little privacy, very little independence. It's hovering over that kiddo and not giving them any sort of autonomy, essentially. So for quite a long time, researchers similar to this over-involvement element of family dysfunction, researchers have also found that families of those with schizophrenia have what they call high expressed emotion. So high expressed emotion is kind of a psychobabble term that implies that this family, there's a lot of criticism in the family. So like a kiddo, no matter how hard they try, they can't do anything right? Everything is always criticized. What they do, then things that they don't do is often highlighted over the things they do, right? In other words, the failures are often highlighted over successes. There tends to be a lot of hostility, so a lot of anger, a lot of verbal aggression, maybe physical, and then a lot of intrusion. So that intrusive nature of expressed emotion, very similar to that over-involvement that we just talked about. And research has actually shown that in individuals who are trying to recover from schizophrenia, if their family has this really high expressed emotion, then their rate of relapse actually increases by 4. Right? So in families with high expressed emotion, the rate of relapse in the individual with schizophrenia increases by 4. So you can imagine what we'll talk about when it comes to treatment here in a little bit. Okay, so What about treatment? We'll get to the whole family dynamic in a minute, but in general, today's treatment of schizophrenia, it can be miraculous. And what your text means by this is that of everybody with schizophrenia, there are about 25% of individuals with schizophrenia who completely recover, right? So no symptomatology whatsoever. Today's treatment of schizophrenia can be modest. And what your text means by that is that these individuals can have residual problems all of their lives, but these residual problems don't rise to the level of impairment that the other symptoms we'll talk about in a minute do. So these residual problems like social withdrawal or vague or odd speech or strange ideas or having very little emotion, they don't lead to the individual's deterioration as much as active problems do or active symptoms of schizophrenia do. Active symptoms, when a person is in that active phase of schizophrenia, can lead to significant impairment, significant dysfunction, significant deterioration, right? So most individuals with schizophrenia, they struggle all their lives, but with medication and with treatment, even though they have these symptoms, they're able to manage them because they're relatively less severe than when they have the symptoms in an active phase of schizophrenia. So the third group of individuals, so today's treatment of schizophrenia can also be a heartbreaking failure. So there are a majority of individuals with schizophrenia who do relapse into that active phase of schizophrenia. And again, this active phase involves those symptoms that are much more debilitating, those hallucinations and those delusions and the odd thoughts and the bizarre thinking patterns, in other words, right? So it's full-blown schizophrenia. Okay, so clinicians, even though the prognosis, right, that means the outcome of treatment is so-so, right? Only a quarter of people actually recover from schizophrenia. Even though it's kind of a so-so prognosis, clinicians, they've come a long way when it comes to the treatment of schizophrenia. Okay, so clinicians are much more successful in treating schizophrenia than they were in the past. So these next few slides are going to be pretty much a review, and I just noticed that picture's covering that sentence, but I'll definitely read it for you here. The next couple slides, they should be a review from chapter 1 when we talked about the early forms of treatment for mental illness. So for more than half of the 20th century, many patients with severe mental illnesses like schizophrenia were actually institutionalized, right? So this again, it should be a familiar sort of trend that we're going to see here. Patients were not responding to the traditional therapies that they used back then. Of course they wouldn't, right? Because many of them were locked up in dungeons and in isolation and treated in very inhumane ways. So the hospital's goals were essentially to restrain the patients, to not, to maybe give them food and very little food, and then some shelter and some clothing. And rarely did these patients see any sort of therapist or have any sort of contact with many individuals. They were oftentimes neglected, essentially. So rarely patients saw therapists, and many times they were neglected. It wasn't until, and let me get rid of that picture so you can see what's happening here. Sorry about that. A little technical difficulty. There we go. So it wasn't until the late 1700s, the early 1800s, with the moral treatment movement, right? So Philippe Pinel, right, came from Europe, or his concept of moral treatment came from Europe, and William Tuke is one of the individuals who was, led the movement. And this movement, it sounds so simple nowadays, but again, it was a huge shift in how patients with mental illnesses were treated. Patients were finally seen as human beings. They should be treated with sympathy and kindness. And so, as a result, in this shift of thinking about how individuals with mental illnesses should be treated, large hospitals, large medical hospitals were actually converted into asylums. Right? So, again, like you heard in chapter 1, the intention of asylums were good, right? They were intended to treat patients with severe mental illnesses kindly and humanely. But because things started working, right? People were starting to get better and starting to improve, but because of this great success of the moral treatment movement, many of the asylums became overcrowded. They were understaffed, right? They grew so big that there were so many patients, but shortages of funds led to staffing shortages, and the quality of care significantly declined. So once again, patients were restrained, isolated, and punished. Those who did not improve were quickly transferred to what your text calls back wards, right? So not backwards, as in we're moving backwards, but back wards. And these back wards were characterized as a very hostile, inhumane, sadistic way of treatment. So oftentimes patients were put in straitjackets, right? They were seen as maybe hostile, they were seen as aggressive, they were seen as non-compliant, so they were given those stereotypical straitjackets, they were handcuffed, and an advanced, again, we're in the half of the 20th century, an advanced form of treatment included that lobotomy, that frontal lobe lobotomy, where they would essentially stick, a tool up through the orbit of the eye and sever the frontal lobe from the rest of the brain. And obviously, patients did not improve. Your text is pretty specific. Patients did not improve. Obviously, they were now pretty much vegetables, even though they weren't psychotic and they weren't delusional and acting out and odd and eccentric and bizarre. Now they were essentially vegetables, right? So even though the mental health symptoms might have diminished, there were obviously other problems as a result of these sadistic forms of treatment. In the 1950s, there were really two main forces or main influences on the improvement in the treatment of those with schizophrenia. So milieu therapy and token economy were developed. They're very behavioral approaches to the treatment of those with schizophrenia. What milieu therapy is it's actually based on the humanistic perspective, more so behavioral. Token economy is more behavioral, but the milieu therapy, essentially what this is it's the idea that institutions can help patients by creating a social climate. In other words, a milieu, right? A social climate is a milieu that promotes productive activity, self-respect, and individual responsibility, right? So it was about giving the individual some sense of self back, right? Some sense of independence and autonomy, some sense of self-worth, right? So they have what a milieu is. It's a group of individuals with a similar disorder where they interact and they're given jobs and responsibilities. And no, they're not huge jobs, right? But maybe like sweeping the floors or help with meal preparation or organizing, the activities like games or I don't know, horseshoes or bingo or things like that, cards that the patients can all play together, right? So that type of organization and interaction, it's all part of the milieu therapy. And again, the idea is that they're trying to enable the person, right? To empower is a better word, the individual with schizophrenia by giving them these activities and boost their sense of self. Okay, so milieu therapy is one approach. And then token economy, like I said, is behaviorally based, and you might have heard of this before, but basically what you do is you have a goal that you're working for, right? So you have a client who might not be brushing their teeth. So brushing their teeth is the goal that you're trying to accomplish. And anytime the client brushes their teeth, then they receive like a check mark or something. So the idea is that they earn small numbers of tokens, and that once they earn them all, they can exchange them for that larger reward, right? They can exchange them for maybe 30 minutes extra TV time, or 20 minutes extra visit, or whatever is really meaningful to the participant or to the patient. And again, the idea is that you're trying to reward socially and even, behaviorally acceptable behaviors. And for some people with schizophrenia, it is their activities of daily living. For some people whose prognosis is poor, right, complete recovery is just not going to happen, then the treatment goal comes, it becomes brushing your teeth and taking showers and fixing meals, and really more of a teaching them to be a little bit more self-sufficient. Okay, so milieu therapy and token economy has really shown to be effective with respect to improving personal care and self-image in patients. And many institutions or many treatment facilities today actually still incorporate milieu therapy and token economy into the total package of treatment. It's not something you would just use alone in order to help treat schizophrenia, but it's definitely part of the package of treatment options for someone with schizophrenia. So really, the prognosis of those with schizophrenia improved with the development of medications. Okay, so medications really changed the way in which individuals with schizophrenia were treated, and ultimately their prognosis. So about the 1950s, antipsychotic drugs were developed. And the drugs, they were developed in the 1950s, but they were developed through the 1960s and 70s and on into the 80s. And the earliest of these antipsychotics are known as first generation or conventional antipsychotics. Okay, so first generation antipsychotics, they tend to focus, or they tend to address the positive symptoms of schizophrenia. So remember those positive symptoms that we went over in class: hallucinations and delusions and psychomotor movements, right? Those positive symptoms, much better than the negative symptoms. Okay, so antipsychotics reduce positive symptoms better than the negative symptoms. So even though this is a great improvement in addressing those symptoms of schizophrenia, some of the problems, or it's actually a group of problems known as extrapyramidal effects. Those are some serious side effects associated with antipsychotics, with these first generation antipsychotics. So extrapyramidal effects are essentially movement problems that can result from antipsychotics. And specifically, movement problems included what they call Parkinsonian symptoms. And I'm sorry, I clicked over because I thought I had a list of examples of first generation antipsychotics, but apparently I didn't put that in this slide. But just to backtrack a little bit, if you're wondering what are examples of first generation antipsychotics, some that you might be familiar with are thorazine or Haldol. Those are two common first generation antipsychotics. But to continue on with our story here, big problem is those extrapyramidal side effects or movement problems, and in particular, Parkinsonian symptoms. So remember, I drew this out on the board in class, but individuals with schizophrenia, right, the problem is is that they have too much dopamine, right? So if our baseline is about here, their levels of dopamine are way too high. So these antipsychotics, as stated here in this bullet point, what antipsychotics do is reduce the level of dopamine, right? But if your baseline level is there and the level of dopamine decreases too much, that is going to start to resemble Parkinson's disease. See if I can write this out there, right? And we have schizophrenia up here. So this level, this window of that therapeutic window, it's very small with antipsychotics. So to reach that therapeutic level, it takes a lot of trial and error. And for some people, psychiatrists can find that level, and it's not necessarily finding that level, but it's how the individual themselves, how they respond. So some people might be great, and the antipsychotics work really well with how they're wired. So their dopamine levels stay within that nice therapeutic window. But for some people, antipsychotics, the way they're wired, they might cause that plummet in dopamine, right? Thus, that patient with schizophrenia is going to develop symptoms that resemble Parkinson's disease. So too much of a dopamine reduction causes Parkinson's-like symptoms. So what that will look like is tremors, other symptoms. They might shake, they might have a shuffle in their gait or the way they walk, show little facial expressions. There's a lot of different symptomatology associated with Parkinson's disease, but that tremor, that shakiness, that shuffle, the facial expressions are pretty common. Okay, so in most cases, individuals who develop these Parkinsonian symptoms, once you stop the antipsychotic, then the symptoms, the Parkinsonian symptoms can be reversed. However, another example of an extrapyramidal effect of these first-generation antipsychotics is something called tardive dyskinesia. And tardive dyskinesia typically appears about 6 months after taking a medication. What tardive dyskinesia is, it involves these involuntary tic-like movements. So the side effects, the individual with schizophrenia develops these tic-like movements, involuntary chewing, so kind of chewing of the mouth, smacking of the mouth, and you can see kind of these images here that are supposed to reflect that tardive dyskinesia, sucking, lip smacking, jerky movements, and not just of the face, but it can involve the entire body. So this tardive dyskinesia, it does affect actually a pretty significant portion of those with schizophrenia, about 15%. And one of the major concerns with these first-generation antipsychotics is that if a person develops tardive dyskinesia, unlike Parkinsonian symptoms, tardive dyskinesia can actually be irreversible. It can cause these antipsychotics, first generations, can cause permanent damage even when the person stops taking that first generation antipsychotic. So it's obviously a very dangerous medication. So second generation antipsychotics, also known as atypical antipsychotics. And now I have the list here. So some of the atypicals you might have heard of. Here's some the common names: risperidol, clozaril, Zyprexa, Seroquel, Geodin, Abilify, etc. Right. So these are your second generations, the ones that were created or developed after the first generations, and they tend to be more effective than the first generations, especially at reducing those negative symptoms. Right. So the negative symptoms that aren't addressed with first gens, it's better. Second generations are much more effective at targeting those negative symptoms. Second generation antipsychotics are also associated with fewer side effects, so much less likely to cause that tardive dyskinesia. About half of patients with schizophrenia take second generations. So, it's about half and half with respect to first and second generations. However, second generations are still associated with some serious side effects. So one of those is agranulocytosis, which I have to kind of enunciate there. But basically what that is it's when your bone marrow doesn't make enough white blood cells to fight infections. So I had to look at my notes there. But the bone marrow, there's not enough white blood cells. So a person, their immune system is compromised, essentially. That is a side effect of second generation. So there are some people who, have to make that decision about reducing the symptoms of schizophrenia, or taking a medication that can possibly leave them immunocompromised. And that's, there's some people with schizophrenia who refuse to take medication. The first gens because of Parkinsonian symptoms, because of tardive dyskinesia, the second gens because of these other side effects. So medication compliance can also be one of the goals of therapy that's addressed with token economy and other behavioral approaches, because med adherence is typically pretty poor with those with schizophrenia. So in general, how effective are antipsychotic drugs? Here are the bullet points that kind of summarize what your text has found. About 70% of those with schizophrenia have a reduction in some type of symptoms, right? So they are quite effective. In fact, they're so effective that antipsychotics appear to be more effective, right? So more effective than any other single approach, and that includes therapy, right? It includes comparisons with milieu therapy, token economy. We're going to talk about cognitive behavioral therapy in a minute. Medications alone are more effective than any other single approach, right? But what we're going to see here is that the absolute best approach to treatment is this combination of medication plus some type of therapy, okay, or multiple types of therapies. Drugs, antipsychotics can produce pretty pronounced improvement within several weeks and reach their maximum level of improvement. It takes about 6 months. So it's not a quick fix, right? It's not something like you can pop a pill and the schizophrenia-like symptoms or the symptoms of schizophrenia disappear. It can definitely take a while. And then it's often a lifetime illness where a lifetime treatment. In other words, where a person with schizophrenia consistently needs to take the medication because relapse rates are pretty high if they were to stop medication. So another approach to therapy, and again, we'll talk about this in a minute. Another approach to therapy is CBT, cognitive behavioral therapy. And before antipsychotics, CBT wasn't even an option for those with schizophrenia. Mainly because those with schizophrenia, when you're actively psychotic, to ask a person to think about their thoughts, it's just absolutely unrealistic, right? When someone can't even distinguish between reality and fantasy, doing these types, the things that are listed on this slide, doing these types of things, it's just not accurate, right? So antipsychotics really help relieve that element of psychosis so that an individual with schizophrenia may be more likely to respond to the therapy like CBT. So I have the major bullet points here about the two different CBT approaches, so cognitive remediation and then hallucination, reinterpretation, and acceptance. And I'll leave that up for you. I'm not going to ask you guys about the details of these different types of therapies, just really these summary points. Another approach underneath the CBT perspective is a new way of cognitive behavioral therapy. And really the idea here is rather than changing or stopping some of those bizarre thoughts, those hallucinations or delusions rather. The goal of this new wave cognitive behavioral therapy is to help clients actually accept their stream of problematic thoughts, meaning help them accept their delusions, right? So people with schizophrenia can be delusional and have these bizarre thoughts, but when they're not actively psychotic, it's absolutely possible for them to be able to essentially talk themselves through that delusion. Okay, and to what this therapy is arguing is, or encouraging, is for patients to essentially just accept it, right? I'm having a delusion. I know it's not real. I know it's not me. It's not my voice. It's not my thought. It's not my impulse. It's going to pass. I will get through this. So the idea again is to accept their positive symptoms and to be able to learn how to cope with it. And so then you can see the other goals of this new wave approach as well. And overall, CBT therapies are helpful and can significantly reduce the likelihood of hospitalizations. And that's even more so when the individual is also taking that antipsychotic. Again, this approach would be absolutely ineffective with someone who is actively psychotic. They're just not able to go there mentally. So you need the patient with schizophrenia to be taking the medication and to be mentally stable in order to even be receptive and then respond to therapy like cognitive behavioral therapy. Therapy should also include, multiple approaches to therapy here, not just medications and not just CBT, but family therapy, right? As we talked about earlier, there's a high rate of relapse in individuals whose family can be described as having that high expressed emotion, right? So families where there's a lot of conflict, where there's a lot of over-involvement, where there's very little boundaries, poor communication, very little privacy and autonomy, right? That's where this therapy would come in and help to make the family unit much more healthy in order to help the individual with schizophrenia improve. So the goals of family therapy addressed that express emotion, create more realistic expectations. Sometimes family members expect the person with schizophrenia to be completely recovered, and that's just not realistic in the majority, in 75% of the cases. So helping the family understand through psychoeducation what schizophrenia is, what the symptoms are, what the prognosis is, and help the family develop a more realistic picture of the prognosis. And then also family themselves can attend support groups, right? So families, even without the patient, can go to support groups, much like someone might go to AA or NA or OA, Overeaters Anonymous. It's possible for families to to join in on support groups where other family members with individuals with schizophrenia, they're able to come together and talk about, process their experiences and what's working for them, so that they could kind of help each other, help each other support the person with schizophrenia. Okay. Social therapy, another option and hopefully part of the package with part of the treatment package. So social therapy overall goal is to help clients address social and personal difficulties in their lives. And this is especially the case for those with maybe more higher functioning schizophrenia, right? So social therapy has a lot of parts to it depending on the patient, depending where they are, right? So, for those that may be more independent, finding housing and supportive care might be an option, whereas for individuals who are more actively psychotic and have, much more severe form of schizophrenia, housing involves inpatient hospitalization, right? So it's gonna differ depending on severity. So all of these, again, differ by severity, but are included in this social therapy. And again, with this, having a therapist who can help someone with schizophrenia with these goals can help decrease the rates of schizophrenia. And oftentimes this is like a social worker, a liaison between the treatment team and between the community who can help build these resources and help really advocate for the individual with schizophrenia and find these resources and help facilitate that connection and so the individual can easily acclimate to a more independent state of living. So the broadest treatment approach is considered the community approach. So what I've been talking about so far has to do with individualized approaches to the treatment of schizophrenia, right? Medications and CBT. And yes, family therapy involves a unit, but it's about the individual, right? Well, this community approach really recognizes the need for the community to be involved in the treatment of those with schizophrenia. So this approach really appreciates that, once again, a patient with schizophrenia, their symptoms can vary in severity. And that, even a single patient, their symptoms vary in severity, right? So how can a community best support this individual whose symptoms vary in severity? So the community approach should include, first and foremost, coordinated, it's written right here, coordinated services. So community mental health centers should be able to provide medications along with psychotherapy and, if needed, inpatient care. Right, so there's multiple options within that one community health center, right? That's the notion of a coordinated effort, right? When you have one facility who's able to serve that client or that patient, no matter where they are on that severity continuum. So that coordination of services. Patients might also need short-term hospitalization, and not every community has that option, right? So, for example, Missoula, Montana, right? And we'll talk about this on the next slide. There's a lack of community resources, and for some people, it's either inpatient hospitalization at St. Pat's or it's living at home, right? But what do you do with those people who are in between, who are not as severe and not as impaired, so they don't need inpatient care, but they're not quite stable enough to live independently, or they're not able to live at home for one reason or another. Maybe family members aren't equipped to take care of those symptoms. So short-term hospitalization is a type of hospitalization that might last a few weeks. And then the patient, so they're inpatient for a few weeks, but then they're released to a less restrictive form of care. So an example of that might be a partial hospitalization where individuals might go for the day rather than inpatient 24/7 hospitalization for a few weeks, like you might see in short-term hospitalization. Partial hospitalization is kind of like day treatment, where the person checks in the morning and the medications are managed and they're receiving therapy, psychotherapy, and milieu therapy. So they're interacting with others, they're getting a lunch, they're getting medications, they're getting, other services, and then they're released at the end of the day, right? It's kind of like a daycare facility, in all honesty, for individuals with these severe mental illnesses. Another option is a supervised residence. So a little less restrictive and a little less management than a partial hospitalization. So supervised residences like halfway houses, you might have heard of that, or group homes, where they provide shelter and they provide supervision for patients who are unable to really live on their own, But patients who don't need hospitalization and don't need that type of micromanagement that you might find in a partial hospitalization and short-term hospitalization, right? So these are individuals who are able, they're high functioning, essentially. I mean, they need some type of monitoring, right? There's some type of supervision, but it's not to the same extent as what you might find in those other options. And then the community approach can also involve occupational training and support. So some people with schizophrenia receive occupational training. So they might gain employment in a workplace with supervision from an employer who has some background in mental illness and mental health and is able to support that individual's training and that individual's effort. Okay, the goal is to really support the client in their attempt to gain employment and to be a little bit more independent, and then consistent with the moral treatment, with increased independence, comes that self-respect and that sense of autonomy, right? And that sense of necessity, and can be very promising for an individual's well-being. So proper community care, when we have communities that have these elements in place and they're able to respond to an individual with schizophrenia's varying levels of severity, it shows great potential for assisting in recovery of not just schizophrenia, but other mental illnesses that are pretty severe. If you have bipolar with psychotic symptoms, for example, right, this type of approach where you have options for individuals depending on the severity, it shows a great, it's really promising with respect to the potential for improvement and recovery. But unfortunately, less than half of those who need appropriate community mental health services receive them. Okay, so less than half. And then even more devastating is that 40 to 60% actually receive no treatment at all. So 40 to 60% of those with severe mental illnesses like schizophrenia actually don't even get one of the elements of community care, right? That community approach, whether it's inpatient hospitalization or short-term hospitalization or partial whatnot. A large percentage of individuals with schizophrenia, research shows, does not receive any treatment whatsoever. And there's two factors that are responsible for this. So one, poor coordination. Right? So many mental health agencies and communities, they're just not communicating, right? And that's not necessarily because they don't want to communicate, but oftentimes people who work at these agencies are busy. They're crazy busy with large caseloads. So the ability to coordinate with another community resource can often be compromised. Because if you imagine if you have a caseload of 20, 30 patients and you're having to call 1, 2, 3 different community resources in order to coordinate care, and it's super time consuming. Okay, so communication can be compromised, not just, it's not like I don't want to talk to that person and coordinate care. It's just oftentimes people just don't have the time. And then, as we see in Missoula, Montana, and many other rural communities, there's a shortage of services, right? Missoula, Montana doesn't have every element of that most effective community approach to care, and as is the case in many rural communities. So largely it's economic, right? It's really hard to recruit providers in a community that doesn't pay what other larger, more urban communities pay. So that's a big shortfall with respect to the ability to provide care. So what happens? What happens to people with schizophrenia and other severe mental illnesses? Like bipolar disorder with psychotic features or whatnot, What happens to these individuals with severe mental illnesses whose communities do not provide the services they need or whose families cannot afford private treatment, right? Pay out of pocket. What happens to them? And this is figure 12.4 in your textbook. And as you can see, a large number of those with severe mental illnesses become homeless. Okay, and your textbook actually gave the figure of how a quarter of the homeless population actually could be diagnosed with schizophrenia. And so you see here, with schizophrenia as well as other serious mental illnesses, there's a significant portion of those that are homeless. There's a significant number of them that are in jails or prisons, nursing homes. About a quarter of them do live with family members, but many more are living unsupervised, no matter their degree of symptomatology, no matter where they are on that spectrum of severity. So it's obviously a huge community health problem. And even though we've come a ways in the treatment of those with schizophrenia since the 1930s and 40s, in 2019, we still have a long way to go with respect to creating options within the community and then coordinating that care. Okay, so that's it for our lecture on schizophrenia. Again, if you guys have questions, you can always look in your text for more information. And if your questions are answered in your textbook, or if there's something you'd like to try to elaborate on, I'll definitely open it up for about 5-10 minutes on Tuesday, and we can talk a little bit more. Thank you.